My hometown is Chittagong, and I have many wonderful memories of Chittagong Medical College between 85 to 90 when my father was there. I used to play basketball with in the Chittagong Medical College campus. I have really fond memories of that place. So we came up with this book. Many authors from UK and USA, like Hafiz Bhai, has contributed to this. This is basically a handbook for Bangladesh. We are on the second edition. The first edition was published on the 2nd of May. This is freely downloadable from my website. Now, this is a preface to the guideline. It clearly says that this is not a replacement for the national guidelines. I know people like Azam Bhai, Jamal Bhai, they have come up with a very nice guideline for cardiovascular disease. And this guide is just to supplement it. If you want a reference guide, then you can have a look at this. So this is not a replacement for the national guideline. You can see the editors there. This is dedicated to Faisal Bhai. Many of you know Faisal Bhai. He was a student of Chittagong Medical College. Sadly, Faisal Bhai died a couple weeks back of COVID after raising concerns about the lack of PPE. So it's really important to understand how important it is to protect our healthcare workers. Now, if I move on to the chapters, so this book is around 180 pages, has 180 pages. Now for generalists or specialists, all you need is to read 30 to 40 pages. So the first one is the important chapter, key recommendations from Bangladesh, then how the testing is done, then a general idea about the management of COVID, and then ICU people can actually look at the ICU management strategies, which has been written in great detail by Tasbir Bhai, who again is an ITU consultant with and pulmonologists like Rumi Bhai. I think these people actually know the whole journey of the patient because they see the patients on the ward struggling with a bit of oxygen. Then they see the progression of the patients to the ITU where they get ventilated. So it's good to have insight from them. Now, there's a very important chapter called Evidence for Specific Pharmacological Treatment. In other sense, it's actually, this chapter contributes to the lack of evidence for any pharmacological treatment. So as Rumi Bhai has said in the previous presentation, if you give supportive therapy properly, most of these patients will survive. Then there's a thromboprophylaxis chapter, which is very important. Then I would advise everyone to go through these infection control chapters where, you know, in great detail, we have described how to protect yourselves. Like, for example, I have this FFP3 mask in front of me. FFP3 is one of the most safest masks. It filters up to 99%. It's even better than the N95 mask. Now, if I wear this like this, there's no use because there's gap there. That's why in Western world, fit testing is done, which I don't think is done in Bangladesh. And it's really important that this is done. So things like that are described in that chapter. Also, how can you reuse your masks, your PPEs has been described there. Now, I want to make one very important point that the coverall that we see that's being used in Bangladesh, I don't think it's a very good idea because it's a very hot, humid weather. And what you do is you get exhausted and you get sweat inside when you use the coverall. It's important not to use the coverall and use it only for aerosol generating procedures. I mean, it's important to be clear which are the aerosol generating procedures. If someone is having CPAP, NIV, ventilation, laparoscopic surgery, diathermy, NG tube insertion, endoscopy, nebulization, these are the aerosol generating procedures. Unless you are doing this, you do not need to wear an N95 mask. Now, the issue of fan and window comes. However, please remember one thing, that if you have a ceiling fan and the window is open, it is actually diluting the air. And as long as you're not giving high flow oxygen to the patient, you should be safe as long as you stay 6 feet away from them, you wear a surgical mask, and you clean your hands on regular interval in between the patients to patients. Then there are the generic chapters where, we have a cardiac chapter. Hafiz Bhai has given a beautiful case report for that chapter. And Hafiz Bhai is also coming up with a second book, which hopefully will be on case-based discussion. Now, if I go to some of the key recommendations, these are very important to know. Focus of management is supportive care. If you give the patient proper oxygen, if you give DVT prophylaxis, if you give therapeutic Lexan to people who need this, and if you give antibiotics when the patient has superadded infection, most of these patients will get better. If you look at this graph, 80% patients have mild disease. They can be treated from home with isolation. Now, for Bangladesh, I know in some homes there are 15 people living. These patients can be sent to youth hostels or somewhere, in a hotel, some sort of isolation facilities. They do not need to come to the hospital. 15% will have moderate to severe disease. These patients will need hospitalization. They will need supportive therapy. Only 4 to 5% will require ICU care. Now, ICU care is very tricky. I know there are lots of limitations in Bangladesh. And don't forget, even in most advanced countries in the world, the ICU mortality is very high. If we look at the New York data, some institutes have 90% mortality. UK overall, the mortality is around 51% for ICU patients. Now, other important things we have incorporated is every hospital should treat COVID and non-COVID patients, and they should have designated zones. This is protection. This is for the protection of the healthcare professionals as well as for the patients. If you keep a red patient in a green zone, he's going to infect all the patients. What's happening now is because we have COVID and non-COVID hospital, if you get one COVID patient in non-COVID hospital, everything just goes pear-shaped and all the patients get infected, which we have seen like in Midford Hospital, which is my, I'm from Sir Silverman Medical College, so my own hospital, 60 healthcare workers were infected with COVID, and that wasn't even a designated hospital. Test is very important. It's important to know that test has up to 30% false negative results. So you have to go with your clinical judgment if you see the test is negative. Oxygen saturation, we have talked about this. I'm going to just show one or two important things because I think the discussions are more important than rather than presenting all these things. This is a very important slide which shows when different tests become positive. You see the RT-PCR test, it can be positive early, and then the antibody test. Antibody tests, there are lots of different tests. Not most of them are reliable. So I think it's really important to develop the testing facilities if possible. And we have to mobilize the whole resources for this. We have to utilize the biochemistry department, microbiology department of places like Chattogram University and other places. Now I want to go to another important place. So this is summary of the treatment of COVID. This is very nicely described in our summary of non-ICU management chapter. Then I will go to another important chapter, which is triage. It's very clearly described how to triage a patient. So when a patient comes to the A&E, important thing is 2 people should receive the patient. One will be doing the documentation, another one will be examining the patient. And these 2 healthcare workers should have full PPE. It's really important because they don't know what's going to come to them, whether a COVID patient who is frankly infective or a non-COVID patient. So it's really important for their protection. Now, there are very simple questionnaires by which you can actually triage them, whether, first of all, do they need hospitalization or they don't need hospitalization? If they don't need hospitalization, what are the instructions you're going to give? When should they come to the hospital? Now, if they are going to the hospital, which zone of the hospital they should go? For example, if a patient comes with a heart attack, no history of fever, no history of contact with any COVID patient, they should go to the green zone of the hospital. On the other hand, if a patient comes with a heart attack who had fever, who had some sort of contact with a COVID patient, he should go to the red zone of the hospital. So these are very important for your own protection. This is the triage form which is used in some hospitals. It literally takes 5 to 10 minutes to fill up this form. And with this, you can actually identify which patient should go to which zone. This is another important chapter about the discharge pathways, because you need to understand how long the patient should self-isolate after being diagnosed with COVID. There are different guidelines. There is a UK guideline, American CDC guideline, Euro CDC guideline. I have put the Euro CDC guideline. So it's very well described there. In summary, if someone is apyrexic for 3 days, you can do a test. If there are 2 negative tests in the space of 24 hours, they don't need to isolate anymore. If the patient has been asymptomatic for 8 days, then they don't need to self-isolate anymore. Now, there is one symptom that can persist, which is cough. It has been seen that cough can go on for 4 to 5 weeks. Someone with cough do not need to self-isolate after 18 days. Now, if someone had critical or severe disease where they needed a lot of oxygen, they were ventilated, they should isolate for 14 days. If you are a healthcare worker, what should you do? Should you just isolate for 7 days? Yes, you should do isolation for 7 days. When you go back to work, you should wear a mask for another 7 days. So these are all things. Now, I want to tell something important. If someone had a COVID test which is positive, then he became negative, then it's been 4 or 5 weeks, then you do a test on the patient, the test is again positive, it not necessarily means that the patient is actually infective. What it means is that the patient has dead virus in the throat, which has been swabbed. We do see this phenomenon from time to time. It's important to understand that this patient is not positive anymore after the index event, even though the test is positive. ICU management, I'm not going to touch this. Rumi Bhai has actually nicely described these things. I just want to show one thing from the prophylaxis chapter. There's a nice flowchart there. In our 3rd edition, we are on our 2nd edition now. Every 2 weeks, we are coming up with a new edition. So our 3rd edition is due in another 10 days. We have made this chart much better. It is, I cannot tell you how important it is to give DVT prophylaxis to these patients. And patients who have critical disease, they must have therapeutic clexane or something. Otherwise, they will die of DVT. If you look at the pathology, there are 2 pathologies. One is ARDS type pathology, where because of stiff lung, the patient eventually dies. Another one is the intrapulmonary coagulation. Those are the patients who can easily be treated by giving therapeutic clexane and stuff. So overall in COVID, what happens is in the first week, patient have flu-like symptom. In the second week, the respiratory symptoms are more predominant if they're progressing in a bad direction. And in the third week, the terminal event is myocarditis. Eventually, the patient dies of heart-lung failure. Now, since a lot of cardiologists are here, I will just show a glimpse of the cardiology chapter. So this is the PPE chapter. Please do have a look at this. It shows how to do donning and doffing. These are all important things. There's no point in wearing PPE when you are not actually doing the donning and doffing carefully. So finally, I'm just going to go to the cardiology chapter. This is a picture taken from JAMA. Hafiz Bhai has actually provided us this picture to show why myocardial damage happens. Now, I just want to reiterate something. Someone has hypotension, someone has electrolyte imbalance. Then if you give the patient hydroxychloroquine and azithromycin, the result is not going to be good. There is a case report that Hafiz Bhai has provided us with. Please go through that and see what the patient eventually had. Patient had torsades de pointes, So TDS is actually not uncommon with this. And we have seen lots of QT interval. Patients had pacemakers. Now you can use these things if you are in a hospital where there's 24-hour monitoring. If you don't have pacing service, if you don't have EP facilities, if you don't have resuscitation facilities, you should not be using both these 2 medications, because we know that there's not a single study that has shown that these medications are useful. There are lots of trials going on, and we should just wait for the trials. trial results. Finally, we have the section where, I mean, surgery, gynae, everything is there. Finally, we come to the section where it shows question and answers. Our plan is to improve this section as much as possible as we go along. So if you have any questions that's coming up regularly, please do email me. We can incorporate the answers here. I think it will be useful for everyone. Finally, a chapter by Tasbir Bhai on future directions. Rumi Bhai has spoken about convalescent plasma. It's a simple method. It's less risky. And in desperate situations, you can use it. A lot of centers are using it. We are using it in Oxford. Early results are good, but we haven't published our results because we don't know what will be the long-term results and things like that. Like a lot of patients, whether they will reach primary endpoint. But if you look at history, they have been useful for SARS and MERS. They haven't been useful for Ebola. Now, TOSI has been used quite a lot. It's part of the recovery trial as well. I mean, the juries are out there. We are not entirely sure how good they are. Vaccine, obviously, you know about the vaccine trial, which is coming. And finally, the biggest trial in the world, the recovery trial, which has recruited more than 7,000 patients. These are the drugs that has been included there. And these patients are included only as part of a trial. Otherwise, we are just giving supportive therapy. In our ICU, we had 4 deaths out of 40 patients that were admitted. We had around 400 to 500 patients who had high flow oxygen, who had high flow nasal cannula, NIV. They all went home. So if you do the basic things right, like give them proper oxygen, do careful fluid balance, give antibiotics if they have superadded infection, most of them will do well. I do not think there is any role or any strong evidence to show that drugs like remdesivir, ivermectin, hydroxychloroquine, azithromycin, any of this works, favipiravir. You can look at the data. There are lots of websites, but please be careful when you look at the data. Have a look at the report, what exactly they have done. Because there's nothing more dangerous than giving drugs that are not useful but has side effects. Thank you.
Thank you, Dr. Shakil Farid, for your excellent talk. So I will take a few questions. If you have any, please, very quick question.
Let me, Dr. Shakil, can you hear me?
Yes, yeah, I can hear you.
Shakil, you are fellow. We are also fellow. You are HCPS, yes?
Yes.
Yes, yes, thank you. You
Yes.
showed your guideline. Very thankful to you. The co-workers working with you, Dr. Tasbir and Dr. Asif, possibly they are working with you or somewhere in
No,
UK?
so there are 40 authors in this
no,
group.
I am saying because these 2 doctors were my internee in Dhaka Medical College.
Who? Tasbir Bhai?
Tasbir and Asif.
Okay. Yeah.
So convey my gratitude to them.
Yeah, sure. I will do that.
Okay,
Thank you.
okay. So
thank you very much.
what my query is, I have a query, please.
Yes.
Query regarding your subject, not regarding actually directly with this presentation.
Yes.
We had a patient 1 month back. He had an extensive anterior MI in our ward, Chattogram Medical College.
Okay.
He had ventricular septal rupture.
Okay.
And X-ray showed bilateral infiltration suspected of COVID infection. He had a history of fever.
Okay.
So we kept the patient in the observation ward. Subsequently, the patient was brought to our ward, put in CCU, and in the same night, the patient died.
Okay.
We failed to do any surgical intervention in this patient, although we have cardiac surgery, in Chattogram Medical College.
Yes.
So, if this patient is in your setting, what should be the ideal treatment? What treatment you offer these patients?
So this is a controversial topic. Okay, there are people who love to go in when this is fresh. They think that that's the best time to address the case, so they would go in, fix the BSD, put the patient on ECMO, and then right through it. Now, it's essential to have ECMO. Otherwise, you'll be in deep trouble if the patient doesn't come off bypass. Now, there is the second school of thought who would say that, no, we are going to wait for 8 to 10 days, let the VSD mature, and then we'll address that. Now, they have presented good results with that because they are doing the self-selected one. The patient you have presented, it's a very complicated case, and we had a situation like this. So what we did was we waited for 3 days, and eventually we operated on the patient after 3 days, and he made an uneventful recovery. He had a long ICU stay, but as I've said, this is variable depending on which surgeon is on call, what kind of facilities is available, whether you can put the patient on central ECMO or not. It's essential to have some sort of backup, either LVAD or ECMO, some sort of mechanical circulatory support after this. So in a place like Chattogram Medical College, I'm not sure, given the type of history, the mortality would be very high anyway. The perioperative mortality, you are looking at 50 to 60%, if not more.
Shakil,
Dr. Anis. Dr. Anis, can I ask any question?
Yes, please go ahead.
Yeah.
Can I just
Dr. Shakil,
about the VSD, because it is an important issue, because Shakil is a surgeon, and the surgeons are like our friends, and sometimes they can be pain. They don't want to take immediately, and then we go for the natural selection. So it is important to give the supportive and also assess the VSD. Is it a right coronary, VSD with the basal septum and close to the mitral valve and spiral sort of VSD, or is it an apical VSD? If it is an apical VSD with the anterior, which is not that common, you may be lucky, and then sometimes you wait, and then we have done cases with Amplarza device on those cases, and get away with this, and not to subject the patient for surgery. However, Shakil will say this, and I will agree with me, that the posterior septal and basal septal VSDs, these are nasty to repair.
Nasty, yeah.
Dr. Shakil, I'm Professor Amol. Happy to hear that you are from Salimullah. I'm the 11th batch. 11th.
Yes, I know you.
I'm working in NICBD. My question: we have a lot of heart failure patients admitted in NICBD with suspected COVID, and we have an isolation ward. You know that our patients are during MI, it is not revascularized properly. So rapidly develop heart failure with ejection fraction less than 35 or less than 40. So frequently we need to use diuretics. So if patient is hemodynamically more stable, BP 120 by 80 like this, can we use diuretics with an open hand, or any restriction to suspected COVID patient or COVID positive patient?
I think the basic thing, which I'm sure everyone will agree, is to keep the patient dry, not to overload the patient. So it's a fine balance between using diuretics and ACE inhibitors and beta blockers and all these things. It needs careful monitoring, extremely careful monitoring.
But no contraindication in ICU critically patient?
No, there's no contraindication. There's no contraindication for ramipril, there's ACE inhibitors, there's no contraindication for diuretics or anything. But what you need to be careful is not to make the patient too dry. As Hafiz Bhai earlier said, it's a fine balance about giving the patient too much fluid or not giving too much fluid. So ideally, what we do is sometimes we do put central lines and PA catheters in patients who are really sick and monitor the wedge pressure and everything and do accordingly. But obviously, in Bangladesh, you have to think about the facilities. So, I don't know how common it is to put SWAN and CVP line, those kind of things in the HQ type of area there.
Thank you, Shakil. Thank you.
Shakil Bhai, I have a last comment on your regarding the VSD. If it is feasible to repair it with the device, is it okay?
Yes, we do send. If it's as Hafiz Bhai has said, we have had patients who had really small VSD and they had device closure. They were absolutely fine. We had patients who had surgery, then the thing dehisced, and then patient had device closure, and it was fine. It depends on the size and the neck and the fitness of the patient. All these things. But one thing we do is we do have impeller and things like that, those kind of backups when we are doing those things.
Dr. Shakil, I am Professor Mir Jamal, Director in ICBD. I like to add, as you know, the mortality of this ventricular septal rupture is very, very high.
Yes.
And we will have to manage clinically the patient, and as well as patient is suffering from COVID. So there are double jeopardy. We shall have to manage the both jeopardy whenever the patient survives, and after a certain time, probably up to 6 weeks, we shall have to wait for stabilization of the ventricular septal rupture, and only then we can do this process, device closure. Otherwise, it is not possible to do the device closure at the acute condition, as because also suffering from COVID. Besides this, in Chittagong Medical College, not only Chittagong Medical College, in Bangladesh, there is no availability of impeller, there is no availability of ECMO in Chittagong Medical College. So we shall have to wait for conservative management, and whenever the patient's clinical condition improves, only then we can think. And regarding Professor Omol's question, like diuretics, there is no contraindication of diuretics in case of COVID patient. It should be used judiciously, provided the blood pressure permits. I like to thank you.
Thank you.
Dr. Anis, Dr. Anis,
Yes.
শুনতে পাচ্ছো?
জি 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 আজম ভাই।
আচ্ছা, আমি শাকিল ফরিদকে অ্যাটেনশন করছি, অ্যাড্রেস করছি। চিটং মেডিকেল কলেজের যে কেসটার কথা প্রবীর দা বললো, সেটা হচ্ছে তার চেস্ট এক্সরেতে বাইলেটারাল ইনফিল্ট্রেশন আছে। That means it is severe COVID disease with respiratory involvement.
Yes.
At that point, it is plain X-ray তে তুমি bilateral infiltrate পেয়ে গেছো। তার মানে হচ্ছে যদি if you do CT, that gives a very very significant clue, and I think it makes sense you not to give a hand in this particular case. Mr. Sir rightly said, because you have to manage very very conservatively. If it test go for COVID, if it is negative, then if it's hemodynamically stable, then go for your further procedure. And second comment, again, Mir Jamal sir mentioned nicely to Amal Kumar Chaudhary sir, because in this guidance, in COVID-19 guidance, we give the just from the observations and recommendations from the various expert opinion. Not we should forget our original guideline. Original guideline we never ignore. We should go for standard treatment, give diuretics adequately without hamper the fluid balance management. If we manage fluid management is okay, done perfectly, then whatever you like to add diuretics, it doesn't matter. You go high dose, intermediate dose, low dose, it doesn't matter. It matter only patient's symptom is improving or not. I think now I may request Anish, can you start for Dr. Chaudhary Hafiz Bhai?
Yeah, of course. I feel that Hafiz Bhai is he's waiting for long, because his time is probably at 6 o'clock in the morning. He's waiting for our webinar. So this is the final our speaker Hafiz Bhai. He will talk on the cardiovascular COVID-19 in cardiovascular practice, today's reality and tomorrow's hope. Welcome, Hafiz Bhai, please.
So thank you. I like the headline given by Azam, today's challenge, tomorrow's hope. So let me go through some key concepts. So let me tell you this. If you look at this slide, this is from JAMA. So when there is COVID infection, first of all, successful infection means that there is virus exposure and the time spent during the exposure. Both are very important. And in the right hand corner, if you look at, we are cardiologists, we should understand this better, that when all the source in radiation in the cath lab is patient. In COVID, patient is the source. However, there are some respiratory droplets and fomites this aerosol may be in the air for some time. So it is very important. Virus does not know the rule of 6 feet. We kind of created this arbitrary rule, but as Shakil pointed out, that the aeration is important, negative ventilation is important, but in the absence of negative ventilation, just use common sense. And the time exposure is important. Distance and shielding. Shielding means all we are doing in terms of using the mask, and depending on the proximity with the source, you need to have the N95 with the 0.3 micron filter. And the distance is also important, right? And the time exposure. But look at the left-hand side. This is very, very important. Early on, if you follow my arrow, this is the time that almost in 2 weeks, virus is done. So if you do the testing of all the RNA-based PCR, you may see, this is the curve, that there may be the RNA is positive, but the virus culture will be negative. So bronchoalveolar lavage or nasopharyngeal swab, all these will be positive, but the infectivity after 2 weeks is gone. So this is important. And the infectivity is very high in the preceding 3 days before the infection actually happens. Why we need to know this? Because when we take care of our patients in cardiology, we need to understand the time course and, more importantly, the pathophysiology of the COVID-19 disease process. The ARDS hypoxia is the virus affecting the lungs, and then there is the inflammation, and then endothelial dysfunction and coagulopathy. Now, if you look at the time course, when the virus is absent in the third phase of the disease, there is still can be problem with endothelial